Go ahead.
Good afternoon, everyone. Thank you for joining us this afternoon. This is Raquel Ruiz-Price, Project Director of the Maternal and Infant Health Center of Excellence. Good afternoon, and thank you for your participation in today's webinar on healthy moms and healthy babies, an update on sexually transmitted infections in pregnancy. Our presenter today is Dr. Amy Harrington. This is a topic area selected by many of you in the organizational assessment we conducted earlier this year. Our goal is to provide you with the latest information and the tools you need to do your work. So I hope that this is a informational webinar to you all. This will be recorded, the webinar will be recorded and will be shared via our website later this week or early next week. Slides were sent yesterday afternoon, so if you did not receive them, please send us a note for us to resend. Our website is www.mihcoe.org. Please use the chat feature during our presentation to ask any questions or make any comments. This is located at the upper right corner of your screen. We will allow about 10 to 15 minutes at the end of presentation to address any of these questions. After the webinar, we will email you a link to a short evaluation. Please take the time, 5-10 minutes, to complete, as your feedback is important to us, and we will use this to inform our future trainings. At this point, I will pass the mic to Dr. Harrington.
Hi, everyone. Thank you for joining us. So again, I'm Amy Harrington, and I am an OBGYN at the University of Virginia. No, that's a big lie. The University of Rochester. I was going to go through my training, and I actually trained at the University of Virginia. So I trained at the University of Virginia, and then I was in private practice in North Carolina before I came back up to Rochester, and I'm actually faculty here at Rochester. I mainly work in our low socioeconomic clinics, working with the residents, the medical students, and I also spend a bunch of time every week at Planned Parenthood. So I'm excited to talk to you all today, and hopefully everybody's going to learn a little bit of something. As healthcare providers and as members of the community, we all have an interest in helping women and their families have healthy pregnancies and healthy babies. STDs are a substantial health challenge that the U.S. faces. The CDC estimates that nearly 20 million new STIs, I'm actually going to refer to them as STIs and STDs. Where I trained, we use sexually transmitted disease. Here at Rochester, everyone talks about sexually transmitted infections, so you might hear me going back and forth between those, but they are the same thing. So nearly 20 million new STDs occur every year, and they account for over $16 billion in healthcare costs. STDs can affect the health and well-being of the mom, but also have the potential to cause lifelong harm to the baby. Today I'm going to review the most common STDs, their impact on pregnancy, and potential preventative measures. Zika, while not common, will be discussed as it is a newcomer to the STD family. So we're going to start with a little audience participation, and I have a poll question for you that will be coming up here in just a second. You guys get to select your answers, and we'll chat about it briefly. Here we're getting there. All right, I'm going to give everybody like 10 more seconds, and we're going to close the question. All right, we're going to go ahead and close it. I'm actually going to show you the results for what people chose. Oh, hang on, it's giving us a few more seconds. You have 10 seconds now. Technology is awesome, but sometimes I struggle with the little details. Okay, so the most common answer that people chose was chlamydia, and that is correct. So when I was a resident, our clinic had a large poster in the hallway with this public service campaign message: chlamydia is not a flower. This has remained one of my most favorite public service messages for all time. If you look actually under an electron microscope, you can see chlamydia is definitely not a flower. The U.S. has really high rates of chlamydial infections. Unfortunately, the highest rates are in young people aged 15 to 24 and in minority populations. In 2014, there were more than 1.4 million new cases reported. These are only the number of reported cases. The number of estimated new cases is closer to 2 million. Here you can actually see New York State, which in 2013 ranked 13th out of 50 states with the most infections of reported chlamydia at 490 for every 100,000 people. This can't all be attributed to New York City, as you can see. In fact, my home city of Rochester has one of the highest rates at 554 cases per 100,000. Gonorrhea is another really common STD. It is a nasty bug, and it's always trying to keep one step ahead of our antibiotics. Increasing antibiotic resistance is actually becoming a real problem, which makes adherence to treatment and prevention a priority. The U.S. also has really high rates of gonorrhea infections, and again, the highest rates are in young people and minority populations. In 2012, there were over 330,000 reported cases, which was unfortunately a 4.1% increase since 2011. Again, similar to chlamydia, these are only the number of reported cases. The number of estimated new cases is much higher at 700,000 per year. New York State does a bit better with gonorrhea than chlamydia in that we rank 20 out of 50, but still not very good. Overall, there's about 102 cases per 100,000 people. Chlamydia and gonorrhea are both bacterial infections that can right now be easily cured with antibiotics. While most of these infections have no symptoms, they do sometimes present with symptoms such as vaginal discharge, bleeding after sex, or pain with sex. Not only can these infections affect pregnancy, but they can affect a woman's ability to safely and successfully have children by increasing the chance of ectopic pregnancies and infertility. When you're pregnant, these infections can increase the risk for bad pregnancy outcomes like stillbirth and preterm delivery. Preterm birth remains one of the most common causes of infant mortality in the United States and in New York State. Besides affecting the actual pregnancy, these infections can affect the baby after it's delivered. These most commonly lead to eye infections. If a mom has chlamydia at the time of delivery, there's a 20 to up to 50% chance of the baby getting an eye infection. This can eventually lead to blindness and is one of the most leading causes of blindness worldwide. Neonatal infection can also cause lung and brain infections, which can be life-threatening. So how do we prevent gonorrhea and chlamydia? Although abstinence, not having sex, and mutually monogamous relationships are highly effective and work for some people, they're not strategies that can realistically work for everyone. We do know that male latex condoms used correctly and consistently can help prevent transmission. But patients need to know that these infections can be passed from any genital and oral contact. Just because it's not vaginal sex doesn't mean it's safe from infection. One of the biggest barriers we see is that people may be unlikely to seek out medical care despite symptoms or even to be screened because of the stigma associated with having an STD. Young age, transportation, low income, lack of insurance, and fear of diagnosis all increase this risk. This is where education, increasing access to care, and making screening part of routine care can help decrease some of these barriers and stigma. While we do our best to try and prevent infections, people are still going to get them. So screening becomes a huge component of prevention. Screening should be done routinely every year in young women, women at risk, and all pregnant women. It doesn't even require an exam. Patients can give a urine sample or can collect a vaginal Q-tip swab themselves. Then, once we find infections, treating them helps prevent their spread. As I mentioned earlier, these are bacterial infections that can be cured with antibiotics. The antibiotics are safe in pregnancy and in women who are trying to get pregnant. Although the patient believes they will never have sex again, especially with that partner, we do see reinfection rates of up to 25% within a year. Patients must make sure their partners get treated. They need to wait for the infection to clear before they have sex again, and we need to make sure that they come back for testing to make sure it's gone and they're not reinfected. So how do we make sure the partners get treated? This leads us to another audience question. So, EPT is A, legal in New York State for chlamydia only, B, legal in New York State for gonorrhea only, C, legal in New York State for chlamydia and gonorrhea, or D, I don't know what EPT is. I'll give you guys a little time here to finish. All right, we're going to get ready to close it here. Give you about a minute each time. Yeah, let's give you a little bit of extra time after here. We're getting close. Okay. So the most common answer is, I don't know what EPT is. Excellent. This is where we get some awesome education. So EPT is expedited partner therapy. It means you can legally write a prescription for someone you have never met. You literally write 2 prescriptions when you see the patient, one for her and one for her partner. The evidence suggests that benefits outweigh the risks of adverse events. In New York State, EPT is legal for chlamydia, and it's a great way to prevent the spread of chlamydial infections. Making sure that patients are aware of this so that even if the provider does not offer, they know to potentially ask for an expedited partner therapy prescription. Even if we can't catch gonorrhea and chlamydia during pregnancy, we can prevent the risk of blindness by automatically giving all newborns eye drop antibiotics immediately after delivery. This is part of the standard of care for all deliveries, but sometimes patients will choose not to give the eye drops, and we have actually been seeing this more commonly out of desire to do things more naturally. This is actually a really good opportunity for education. So on to syphilis. Syphilis is caused by another bacteria. I do think this one looks kind of pretty under a microscope until you think of it worming into your body, then it's not so pretty. But here we have another poll question. So syphilis is A, a disease that is almost eradicated, B, easily identified by sexual partners, C, an STD that can be prevented by a vaccine, or D, a disease that you can get more than once. All right, we're going to go ahead and close it here. Gives us the final few seconds. All right, so you guys did awesome with this one. Syphilis is a disease you can get over and over. So unfortunately, syphilis is on the rise. In 2014, there were 20,000 cases reported for a rate of 6.3 per 100,000 people, which was an increase of 15.1%. In New York, at 7.5 cases per 100,000, we're seeing even higher rates. And these rates are especially high in African Americans and Hispanics. Unfortunately, this also means that we are seeing an increased number of babies born with syphilis, also known as congenital syphilis. Women can pass the infection directly to their babies during pregnancy. Again, the New York State rate of congenital syphilis is higher than the national rate. Over the past 5 years, there were 64 cases of congenital syphilis diagnosed in New York State. This is incredibly distressing, as syphilis can be devastating. Women with untreated syphilis in pregnancy have a 40% chance of the baby not surviving. Babies who are born alive but not treated can have serious developmental delays, seizures, and deformities. Syphilis is caused by a bacteria, and it is easily cured if found early. You can catch it by having contact with a syphilitic sore called a chancre. These can be on the genitals, in the vagina, the rectum, even on the mouth and lips. Similar to gonorrhea and chlamydia, you can get it through any type of sex. The problem with syphilis is that most people do not recognize the initial sore, or it's located in an area that's not visible. As this sore is painless, it can be easily missed. If it's not treated, it can lead to severe neurological infections, dementias, and death. So basically, it's really bad. One of the misconceptions patients have is that if you clean really well after sex or even douche, that you can prevent STDs. Not true. You just can't just wash away an STD. So similar to other STDs, avoiding risk and using condoms can help decrease transmission. But education and screening are really important things that help with the prevention. All pregnant women should be tested for syphilis at the first prenatal visit, and it is just a simple blood test. If infection is detected, prompt treatment with penicillin will cure the disease and prevent transmission to the baby. Partners should also be alerted and also treated to prevent reinfection. So on to herpes. Despite the fact that HSV or herpes is extremely common, it is a disease with a lot of social stigma. Patients often have a great deal of emotional distress with this diagnosis and can be ashamed or hesitant to tell their providers or partners. So we got another poll question here. So which of these is incorrect regarding herpes? A, suppressive therapy in pregnancy is safe and prevents outbreaks. B, women should have a cesarean delivery if lesions are present at the time of delivery. C, all pregnant women should be screened for herpes. Or D, breastfeeding is safe in women with herpes. So again, we're looking for the 3 of those are correct and 1 is an incorrect statement. Give you a little time. All right, we're down to like 7 seconds here.
Okay, so what does that mean?
All right, so a little bit more all over the place here, but the actual correct answer is that this is one of the STDs that the CDC does not recommend routine screening for. So herpes is caused by a virus. It's different from a bacteria in that antibiotics do not cure it. Once you have it for life. Most people have silent infections, but a lot of people do get outbreaks. Again, genital and oral transmission is the most common way to catch it, but moms can pass it to their babies during pregnancy and delivery. Approximately 776,000 new cases are diagnosed every year, and 24 million people are living with a known diagnosis. Unfortunately, you can shed the virus and pass it on, even if you have no lesions or symptoms. Most herpes infections are transmitted by people who don't know they have it or have no symptoms at the time. It's estimated that actually 16% of the population has herpes, and 81% of those do not know they have it. So primary herpes is when you have your first outbreak. The presentation can be very variable. Patients can have no symptoms, or they can have severe outbreaks, which you can see a picture of above, which you're definitely going to be aware of. Recurrent infections are most commonly what patients get diagnosed with. The classic presentation for these is they have 1 to 2 little sores or vesicles that break to form painful ulcers. So while distressing, herpes in pregnancy doesn't typically really hurt the mom, but neonatal herpes can be devastating. So deaths from disseminated or neurological infections can be as high as 30%. In addition, 20% of the babies that survive herpes can have long-term neurological and developmental problems. Most moms who deliver babies with herpes have no history of having herpes. Just like with the non-pregnant patients, most infections in pregnancy are silent. Passing along to the baby is highest at 30 to 50% if you get a new primary infection near the time of delivery. Among women who have known or recurrent herpes, approximately 75% of them are going to have at least 1 recurrence during the pregnancy, and about 14% of them are going to have symptoms or a clinical recurrence at the time they present for delivery. Even with an outbreak at the time of delivery, if it's recurrent disease, the risk of the baby getting infected is less than 1%. As herpes isn't a reportable disease, we don't have great numbers, but it's estimated that 1,500 babies are born with herpes every year. As I said earlier, there's no cure for herpes. There are antiviral medications, but they treat symptoms and not the disease. These medications can be taken to try and prevent outbreaks and to prevent the virus from shedding. So if you have herpes and your partner doesn't, you can take a medicine like Valtrex to try and prevent herpes from being passed on to your partner. Preventing babies from getting herpes involves several things. Providers really need to talk to their patients about the risk, and patients need to be able to confide in their providers. If you're pregnant and you have a partner with herpes and you do not have herpes, you should really avoid sex during pregnancy, especially during the last trimester. If you yourself have known herpes, you should take suppressive medications like Valtrex to prevent outbreaks during your last or third trimester, and they are very safe in pregnancy. And then finally, if you have an outbreak around the time of delivery, even though the risk is only 1%, C-section should be considered because herpes can be so devastating for the newborn. So there are lots of viral infections that can complicate pregnancy. The safety of breastfeeding is always a concern that people have. So this leads us to our next poll question. Women should not breastfeed if they are infected with hepatitis B, hepatitis C, HIV, all of the above, or none of the above. I'll give you some time again here. All right, I'm going to go ahead and give you a few more seconds as we close it out. All right, so here are our results. So basically everybody chose one of two answers, and actually the answer is HIV. Hepatitis B and C have minimal risk of transmission through breast milk, and so it is encouraged, so that we should be encouraging women even who have hepatitis B and C to breastfeed. HIV is the one that we say do not breastfeed. Some pretty little pictures of hepatitis B and C. So Hep B and C are caused by viruses similar to herpes. Most people have no symptoms. You can get it from blood and from semen. These viruses can live outside the body for 7 days, and they can actually be present even if blood is not visible. Hep B is mainly transmitted by sex, Hep C mainly by blood. The good news for Hep B is that 85 to 95% of adults who actually get Hep B are going to clear the virus on their own. The rest remain chronically infected and can be at risk for liver disease. Hep C isn't as good. 50% of the people are going to progress to chronic infection, and they become at risk for liver disease. Now that we actually screen for infections in our blood supply, most hepatitis C is no longer transmitted through blood, but transmitted by IV drug use. And unfortunately, over the past few years, the incidence of hepatitis C has been increasing. Hep B, on the other hand, is actually a bit of a success story. We actually have a vaccine for it. So since 1991, the rate of hepatitis B has declined 82%, and this is mainly due to routine vaccination and to routine vaccination of children at the time of delivery. Screening is, again, a simple blood test. All pregnant women should be screened for hepatitis B. However, for hepatitis C, screening is really only for people at risk. There are some treatments for chronic hepatitis B and C, but they are not currently recommended or given during pregnancy. So preventing these infections involves avoiding high-risk behavior, contact with blood, sores of an infected person, preventing needle sticks, and using condoms. These viruses are not spread through normal things like food, water, sharing utensils, breastfeeding, hugging, kissing, hand-holding, coughing, sneezing. They really are only blood and sex transmitted. The most important thing you can do to prevent hepatitis B is to get vaccinated. So worldwide, mom to baby is the single largest cause of chronic hepatitis B infection. Most hepatitis B gets transmitted during the actual labor and delivery. So if you have hepatitis B and no treatment is given to the baby at time of delivery, about 10 to 20% of the babies are going to get the infection. If you have Hep B and also Hep E, not something we really talk about, but people can have, it does basically not much of anything on its own. But if you have it and Hep B, the baby has a 90% chance of getting the disease. And so remember, chronic disease in adults is only about 10 to 15%. In contrast, babies who get it from their mom have an 85 to 95% risk of chronic disease. So it's really bad to get this disease as a newborn because it is very unlikely to go away. While we can't prevent the virus from crossing the placenta during the pregnancy, we can try and prevent the 85 to 95% of cases that occur during labor and delivery. So if mom is infected, we can actually give her Hep B immune globulin. We can actually give the baby Hep B immune globulin and the vaccine within 12 hours of life, and it massively decreases the chance that the baby's going to get infected for anything that might have passed during the delivery. C-section is not indicated, and all pregnant women should be encouraged, and all women with hepatitis B should be encouraged to breastfeed. The risk of transmitting hepatitis C to your baby is much lower than with hepatitis B. The amount of virus in your system does correlate with the risk of transmission. So obviously, if high levels, you're more likely to transmit it to your baby. This is why getting the disease under control or being treated prior to pregnancy can decrease your risk of passing it on to the baby. There are limited things you can do for prevention if you have Hep C of passing it to the baby after the pregnancy has already occurred, but things like C-section and avoiding breastfeeding do not decrease the risk. So on to HIV. All right, we got a poll question again. So all of the following decrease the transmission of HIV from mom to baby except A, antiviral therapy during pregnancy, cesarean section if your viral level is less than 1,000, infant AZT after birth, or avoiding breastfeeding. Poll is open. All right, we got about 20 more seconds here. All right, so most people got the right answer here. So C-section is indicated if you have very high viral levels, but less than 1,000, there's actually no increased risk from having a vaginal delivery. So the take home from this question is that while some women do need C-section if they have HIV, most women are not going to need it. While HIV is less in the news than before, it's still quite common. In 2013, there were over 47,000 estimated new cases. In New York State, we aren't doing well. We are 4th out of 50 in the highest number of cases diagnosed each year. And that's actually rate, not just number of cases. It's estimated that over 130,000 people are living with HIV in New York State. If you think about your lifetime risk, if you live in New York State, your risk of HIV is 1 in 69 versus someplace like Montana, where your risk of getting it is 1 in 578. So HIV is a lifelong viral infection with no cure. If untreated, it can lead to the destruction of cells that fight disease and cause AIDS. It now can be really well controlled for most people with antiretroviral therapy. Transmission, though, is still through sex, needles, and from mom to baby. 30% of new HIV infections are transmitted by people who do not know they have HIV, which is why screening is so important. The CDC advises routine HIV screening of adults, adolescents, pregnant women in all healthcare settings in the United States, and we're really recommending an opt-out approach, meaning we plan to do it unless you tell us not to. All pregnant women should be screened each pregnancy, and everyone else should be screened at least once in their lifetime. In an effort to control the disease, in New York State, if mom is not screened in pregnancy, her baby cannot go home until it has been screened in the hospital. Screening is simple. Again, it's a blood test. We have rapid tests that actually can be back within minutes. And while these tests are highly accurate, unless it's an emergency situation like active labor where we would want to intervene, all testing should be confirmed with a second test to prevent false positive results. So how do we prevent people from getting HIV? Well, so the big thing that we do know is that treatment is great prevention. Antiretroviral therapy can not only keep people healthy, it can decrease the risk of transmission by up to 96%. And so when we talk about treatment, we're talking about HAART, or highly active antiretroviral therapy. So that's combination regimens where you take 3 or 4 drugs. They tend to work the best, and then they also decrease the chance of them not working by the HIV developing resistance. The drug regimens are still not easy, but they are way better than they were in the past. They are simpler and a bit more tolerable. So we also know that using condoms correctly and consistently, so every time with sex, with an HIV-positive partner or even a new partner that you don't know their status, can decrease the risk of getting HIV by up to 80%. We also have something called PEP, which is post-exposure prophylaxis. This is something that can be used in emergency situations, like after a needle stick or a sexual assault. It involves starting HIV medications as soon as possible and definitely within 72 hours. The sooner you start them, the better. And then you do have to take them for a month. The newest prevention is called PrEP, or daily pre-exposure prophylaxis. And I have started seeing this a little bit on news and in regular media. But this involves taking a single pill containing 2 HIV medications daily if you're in a high-risk situation. So it's not if you have it, it's if you are negative, but your partner might have it. You take it daily, and it can decrease your risk of getting HIV by up to 90%. When we think about high-risk situations, those are going to be people who are survival sex workers, HIV-negative women with an HIV-positive partner, and those who are incarcerated. So most children with HIV or who have died from HIV got the disease from their mom. Transmission from mom to baby can occur at any time in the pregnancy, during labor, delivery, and during breastfeeding. If no interventions are done, 35 to 40% of babies are going to get HIV, which is just unacceptable. So how can we prevent transmission to the baby? We know that the earlier we can make the diagnosis and start treatment, the less the risk of transmission. So we encourage everybody to get screened, and you get screened as early as you can in pregnancy. We encourage women to take their anti-HIV meds during pregnancy, during delivery. If they have high viral levels, they should get a C-section. Babies should get AZT for up to 4 to 6 weeks after birth, and we strongly encourage not breastfeeding. These things can prevent transmission in 99% of cases. These things work. We know it can prevent disease being passed to the baby. These meds have been used and studied in pregnancy for some time now and are considered safe. Any potential risks that people have come up with or theorized are greatly outweighed by the decrease in transmission of HIV to the baby. So one final thing about HIV, we talked about PrEP, and so as PrEP has recently become available, there have been questions about the use of it in pregnancy. So while there's limited studies of the actual use of PrEP in pregnancy and breastfeeding, the 2 drugs in the pill have been studied and are used as part of regular antiretroviral therapy. So we have no reason to think that it would not be okay for women at risk to use during their pregnancies or when you were trying to get pregnant. And finally, on to Zika. So our newest STD. So in New York State, as of the beginning of August, there were about 537 cases of Zika identified, which has gone up now. All of them were travel related, and all except one were from out of the country. As of the end of August, we had 22 homegrown Zika cases, meaning people who had acquired Zika while living in the United States and not traveling, but those people are mainly coming from lower Florida. We really have not seen any homegrown Zika in New York State yet. So the virus is passed by mosquitoes, and unfortunately we've also now found that it's passed from mom to baby during the pregnancy and from partner to partner during sex. Most people are asymptomatic, so not going to know whether they've had the infection, and even if they do, it's usually mild, like you have a little bit of a cold or the flu. Sorry, I'm skipping my slides. We have been able to show a link between the virus and bad pregnancy outcomes. So things like miscarriage and microcephaly are the most common. So microcephaly is where the head and the brain are small, and this can lead to lots of lifelong neurological problems. These can be mild or severe, and they usually correlate with how severe the microcephaly is. So if you have a really small head and a really small brain, there's going to be more severe problems than a kind of small brain. Infection occur at any time in pregnancy, and it appears that earlier infections are associated with either the miscarriage or microcephaly, and later infections can be associated with poor growth of the baby and even fetal death. So while there is testing now available, there is no vaccine and no cure. Surveillance of the baby with frequent ultrasounds is about all we can offer at this point. So the best way to avoid Zika is to avoid mosquito bites, especially if you live in areas with known Zika. So that's just our common thing that we tell everybody. Use insect repellents, long sleeves and shirts, screens on your windows, and really trying to get rid of reservoirs where mosquitoes might live, like big pools of water. For the sexual and pregnancy parts, though, we fall back again on the don't have sex, and if you do, use protection. However, we have some more specific recommendations. If you are pregnant, we recommend that you do not travel to Zika areas. If you're pregnant and your partner had Zika or traveled to Zika areas, you should use condoms or not have sex during the entire pregnancy. If you're thinking about getting pregnant and there is a concern with Zika, you should wait. So we recommend that women should wait 8 weeks, but men should wait up to 6 months as the virus can stay in the semen for a long time. So all this is good advice, but not much you can do if you live in a Zika-infected area. So that's all I've got. I know it was a lot. I have a few more poll questions so everyone can test their knowledge, and then we'll move on to questions and things at the end. So the first one, reasons that women do not get screened for STDs include stigma, transportation, fear, young age, or all of the above. Everybody's answering really fast on this one. I like it. Okay, we're going to go ahead and give you a few more seconds here. All right, so an overwhelming answer of all of the above, which is definitely correct. All right, our next one. I'm getting it here, sorry. Okay, nope, hang on, it's coming, here we go. So prevention of neonatal chlamydial infections includes all of the following except, so A, expedited partner therapy or EPT, B, antibiotics for suppression in the 3rd trimester, C, test for reinfection, D, condom use. So again, I'm looking for the one that is not part of prevention of neonatal chlamydia. All right, we're going to go ahead and close stuff down again here. We're going to show you the results here in just a second. I'm not going to lie, I'm disappointed with this one. I feel like I didn't do a good enough job. So the actual answer is antibiotics for suppression. So we don't give antibiotics for suppression. You do stuff like that for the herpes virus, but trying to prevent neonatal chlamydia, right? So we treat the partner, we treat to make sure the infection went away, and we make sure our patients are using condoms. All that prevents neonatal chlamydia. All right, on to our next one. So a vaccine to prevent STDs is available for syphilis, Zika, HIV, hepatitis C, or hepatitis C. All right, everybody's doing awesome. I'm going to go ahead and close this one early. All right, so overwhelmingly people did choose hepatitis B, which is true. That is the only one that we have a vaccine for. No vaccines for any of the others. People have been looking at vaccines for HIV and hepatitis, but there's such squirrely little things that are always changing that it's really hard to track them down. I've got two more questions here. So this last one is about PrEP, or the pre-exposure prophylaxis. So pre-exposure prophylaxis to prevent HIV in women at risk, A, has been studied and is known to be safe in pregnancy. B, has a drug combination that has been used in pregnancy and has a reassuring safety profile. Or C, is contraindicated in pregnancy due to risk of fetal birth defects. I'm going to publish these for you here in just a second. So most people did pick the correct answer, that it is a drug combination that has been used in pregnancy for other things, and so it has a reassuring safety profile. We just still haven't had this pill specifically studied in pregnancy. All right, final question here coming up. So prevention of neonatal hepatitis B includes all of the following except, so I'm looking for the one that is not correct. So maternal vaccine prior to pregnancy, vaccination of the baby after delivery, immunoglobulin to the baby after delivery if mom is infected, or D, avoiding breastfeeding. About 10 more seconds, then we can publish the results up. So the majority do have it here, right? So this is the one where we want you to breastfeed. The only one you cannot breastfeed in is HIV. Everything else here decreases the chance of baby getting hepatitis B. All right. So I got a few reference slides where we throw up everything that no one can really look at. But I do have a few final thoughts. So one of the big take-homes is that education and removing stigma is really important. So talking to your patients about, the people you come into contact with about getting screening and being open and talking to you about it is really important. Screening really is the key to prevention. And then also for women to know that they can have healthy pregnancies and healthy babies even if they have an STD. For more information, if you go to cdc.gov, they have great resources, and they really break down all this information state by state, and you can even find your own regions. And so that's it. Questions that people have? Somebody's got to have a question for me.
So if you want to look at your chat box, place your questions on the chat box. We'll wait a minute or two here to see what questions you may have.
And actually, something came across my desk last night that I read again that I hadn't put in here, but Zika. We do think it is completely safe to breastfeed even if you've been exposed to Zika. So we are still encouraging that. Just HIV. Everybody else should breastfeed.
So as you're thinking about questions or comments you want to make on the chat box, think about how you might use this information. Think about what list of referrals you may have already on your, if you have a list of referrals, what STD clinics or Planned Parenthood, do you have those lists of where you can refer the women you're working with to get screened for for sexually transmitted infections?
We know that a lot of women actually do see their OBGYN as a primary care physician. They also are going to present to Planned Parenthoods and health departments. And so when their partner, when they get diagnosed and they need to have their partner treated, lots of times I'll ask and they'll say, well, you know, my partner is like a 22-year-old guy and he doesn't go to the doctor.
Mm-hmm.
So they definitely can go to Planned Parenthoods, they can go to local health departments. And then again, thinking about expedited partner therapy for chlamydia. Is that when we can prevent with just a prescription?
And if you're going to your OBGYN or primary doctor, encouraging the women that you work with to ask the doctor, the clinician, to do a screening for the sexually transmitted infections. Sometimes when we go and get our yearly annual exam, a pap smear, we may assume that our doctor is conducting these screenings, and sometimes they may not always be doing that. So encouraging your women to proactively ask, could you please conduct a screening for chlamydia, gonorrhea, and so forth. So informing your women that not to make an assumption, but to actively ask their physician. And so I think we have a couple of questions that just arrived in our chat box. Give me a second here to look. Is that a calling number?
No, third and fourth.
Could Dr. Harrington speak a bit about how to bring up the topic of STDs and screening with pregnant women, especially those who say they are in a monogamous relationship? Oh, fantastic question. Yes.
Now, this is a great question. So I think one of the best things that we have is that we have recommendations and guidelines that we can fall back on. So the CDC, so if we're talking about things like gonorrhea and chlamydia, the CDC says as part of routine health care, you should be screened every year up until the age of 26. So that is actually a nice, easy way when patients say, well, but I've been with the same partner for 2 years, or they say they haven't been with somebody before. I usually fall back on, that's wonderful, but the CDC really does recommend, and a lot of times I'll bring up the American College of OBGYN, all of that, but basically that this is just part of routine care, just like we recommend mammograms, just like we recommend getting your pap testing, this is recommended for everybody.
Right.
And then I bring up the monogamous stuff a little bit because I address it outright. You know, I usually ask people, you know, do you think you are in a monogamous relationship? And just even bringing it up sometimes allows patients to say, well, you know, I actually don't know. Or people say, well, you know, I've been married for 4 years, and a lot of times then we just assume, well, then there's no way. And I find that bringing it up and just asking directly head on people will tell me things. I will have people say, well, actually, I'm having an affair outside of my marriage, or, you know, I'm not so sure what's going on with my partner. And I think a lot of times people are hesitant to bring it to us, but if we address it to them as if this is a common thing that happens, they are more likely to respond and give us information.
Right. When I worked at our local STD clinic here, I had many couples coming in together. So maybe you're suggesting that they go together and do it together versus him going by himself and getting tested or screened if she's already done it herself. So many times I encouraged that, and they thought it was a good idea. Many times they came together, and when I spoke to the partner, he would say, well, I'm here because my partner, you know, she said I should be here, and we're here testing together. So hopefully that's helpful to you. If it's not, maybe if you want to add another comment in the chat box. Did you want to say
just with the next one?
question?
Yeah, because they overlap a little bit, but there's one more.
So the next question is just to cover how CHWs can maybe start this conversation if they haven't had a lot of experience working in sexual health.
So, you know, when I think about just education with people, I never just come out and say, so, have you had a sexually transmitted disease? And I'm assuming when we think about community health workers, you're looking at bigger picture too, like things like, do you see your doctor regularly? Do you get your vaccines? Are you getting your flu shot this year? And so I bring it into those same kind of things. Have you had your screening? For, you know, or I'll say, have you seen your gynecologist? Have you had your screening for sexually transmitted diseases? Have you thought about birth control? What are you using? So I just kind of slip them in with other questions that we typically ask people that nobody bats an eye about. And if you just bring it in as this is all part of women's health and preventative health, not something like dirty that we shouldn't be talking about, women are going to be more open and responsive to it. And also, you feeling comfortable bringing it up is really important. If they see that you are uncomfortable asking that question, they are going to potentially feel less willing to discuss it with you because, again, it's like this is something dirty, secret, something we shouldn't talk about. So making it matter of fact, this is just part of what we do, what we talk about, is really important.
The next question is, how long does the Zika virus stay in a mother's system?
So we don't know 100%. Right now, we've seen it for probably at least 4 to 6 weeks, which is why we're saying 8 weeks. It does not appear that we've seen it after 8 weeks. That is different, though, from the men, where we're knowing it can live in sperm for months and months and months.
Next question is there a recommended length of time for a person to consider themselves safe, I guess, you know, the keyword safe, right, in a monogamous relationship?
So that's a tricky question, right, because that depends on your social situation, the communication you have with your partner. You know, unfortunately, we never can know exactly what somebody else is doing. We can know what we're doing, but we can never be 100% sure of what somebody else is doing. So I do always tell people, anytime you are with a new partner, you should get tested. The other thing is, for some things, it can take up to 6 months for them to show up in your body, specifically things like hepatitis and HIV. So when you've been with a new partner, I recommend you get tested, you know, after you've been with them, but then about 6 months later, to really make sure there's nothing there. In terms of then how often should you? Again, if you are under age of 26, you should get screened every year, just routine screening. And after that, it's really just going to depend on your own situation. But I always tell people, if there's any doubt or any concern, get screened. It's better to know than to not know. Okay, those are great questions, guys.
That was our last question there. Any other comments, questions? Please post on the chat box.
This was fun, and I actually really enjoyed doing it. And so I would love any feedback that you have, especially with the evaluation forms, whether you felt like any of this was beneficial, if you would wanted more information on one thing or not. I would really appreciate it so I can keep making this better.
Another question here. You mentioned the importance of being comfortable talking about STDs and sexual health. Can you give any tips to become more comfortable? Say practice. Right?
Yeah, that's what I'm going to say. Practice. You just got to do it. You just got to do it over and over again. And you'll find, like, you know, the first person you're talking with it about, it may be a little bit awkward. It may not go so well, but just keep doing it. And the more you do it, the more comfortable you're going to be doing it. You know, we always say practice with a friend,
right.
Practice with your coworkers, you know, asking those questions. But you just have to do it. If you don't do it, you're never going to get comfortable.
Right. Yeah, I did sexual health for a long time. I worked at the STD clinic for a number of years, and so doing the practice, and we would practice in our center, practice on how to ask questions and, you know, how to frame the questions too, right? So if you have a colleague, you know, set some time aside, a half hour, working with your colleague about how would you present this information to your women, and what questions would you ask them, and also having that referral list and local referral, the resources to give to them. But I think the best way to get comfortable is really practicing, knowing what questions to ask and practicing how to ask those questions. Yeah. So is there any information about rising perinatal HIV transmission?
So, especially in
New York specifically. Yeah.
So there is a great website, which I'm blanking on right now. Hang on, let me pull up my thing here. That specifically tracks HIV across the country and breaks it down by state. I think if I actually put it on this one. I don't know if I used any of their pictures, so I might not have. But there is a great website for that. If you just Google HIV in New York State, it comes up. And we actually, while people are still getting HIV, we aren't having huge increased rates of perinatal HIV because we screen our pregnant ladies.
Yeah.
We're screening them, and so if we're identifying it, we're getting people on treatment right away. And if you can identify it and get them treated, even if you don't find it till the end and purely give AZT in labor or AZT after the baby has been born, that alone massively decreases transmission. So we've actually got a really good hold on preventing HIV, perinatal HIV.
Good. And I want to thank somebody, if you want to
I'm going to
look for that website.
I'm going to look for that website. I wish I,
While she looks for that, there was a comment here. I did enjoy the presentation format, so thank you for that positive comment. I appreciate that. Again, questions, you know, you can potentially ask your women is, are they in a relationship? How long they've been in a relationship? When was the last time he was tested? Would he be open to getting tested together? Because you also want to make sure that it's not a potential domestic violence type of situation either. So does she think that he will be willing to get tested? Is he open to the fact? And then, you know, sometimes women, you could do a role play with her. How would she ask him about getting tested together? So I would also, as a CHW or home visitor, consider doing a role play with her on how she would frame that with him, you know, how she would present it to him so that she is comfortable at the point that she does get to talk to him about it.
I strongly encourage that. One of the other things is when I diagnose, I'm like, how are you going to talk to your partner about it? It's super easy when they're like, well, I kicked him out of the house, you know, 3 months ago or something. But, and always assessing for safety.
Yeah.
Because domestic violence is huge, and especially if you have someone who thinks they're in a monogamous relationship, and they end up with a disease that they are pretty sure it came from their partner. they are at high risk. So you do need to assess that. You don't just send them out the door saying, good luck.
Right, exactly. There's one more question here. Could the COE share some of these prompting questions with the Mitch programs so they can practice incorporate into their work? Well, certainly, if you, I don't know which prompting questions you're referring to, but if you want to send me an email of the prompting questions we had suggested here, and we can work together, Dr. Amy, on some of these that we can share that could be useful as a starting point.
The other thing, there are some great websites also. So AIDSVU.org is the one where you can get really state-specific information, and we will email that. We'll put it into the chat so that you can see it, but we can also email it to you.
AIDS, right?
AIDS.
Is it VU?
Yeah.
Like VU.
Yeah. .org.
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 Is that right?
AIDSVU.org. Yep.
Okay. So we've posted a website that Dr. Harrington is referring to. All right. One last question. Thank you. One last question. Is there a way of knowing if an STD was transmitted sexually or any other way?
So, unfortunately, with things like gonorrhea and chlamydia, we pretty much know those are going to be sexually transmitted. Although, again, oral, it can be oral, vaginal stuff, but it's still, those are going to be sexually transmitted. When you're talking about things like hepatitis, HIV, and my brain's not working, and hepatitis C, those we really can't tell, right? We can't tell if those came from blood or sex. So a lot of that just depends on your clinical situation. It is really hard to get hep C through sex, but you can. So most of the time those are presumed to be through some sort of drug or blood exposure. But most of the time for HIV or hepatitis, you can't say exactly where it came from. And then
there was a follow-up as in like a vaccine or through contact. They can do titer tests to see whether you had a vaccine, how long ago.
For hepatitis, yeah.
But in terms of transmission.
No, not in terms of transmission. We can definitely do testing to see whether you have antibodies to disease from a vaccine or if you have had the disease yourself. But for the most part, how you actually got it, that we can't tell people.
Right. These have been great, fantastic questions. If you have any other questions post this webinar, please send it over to our email, mihcoe@urmc.rochester.edu. Please send it over to us, and I'll be sure to share it with Dr. Harrington and get you a response. So thank you for your participation today. Hopefully this was helpful and information to you, and you have more tools in your toolbox here to do your work. Thank you so much, and have a wonderful afternoon. Thanks. Bye-bye.